So the updated data from the BRIGHT trial, I think, is really confirmatory of what the StiL trial showed. So the initial presentation of BRIGHT was really a comparison of response rates and was deemed to show in non-inferiority of bendamustine rituximab in terms of the complete response rate, which it did at the primary analysis. This longer-term outlook is really designed to see what the efficacy of it is in terms of progression-free survival and event-free survival. And in terms of that, I think we have to understand the limitations of the study. It wasn't initially designed to look at those endpoints in a rigorous way. In this trial, as opposed to the StiL trial where CT scans were done regularly, this was really done per institution based on institutional practices. But at the same token, I would say it's very much in line with what's done in clinical practice. So in our own institution, we're certainly not imaging patients on a routine basis, and more frequently we image based on clinical need. So although these endpoints were not built in as primary endpoints of the study, I think the way that the data was captured is quite in line with clinical practice. And reassuringly, what they did show is that the event-free survival, progression-free survival was better for BR compared to either CHOP-R or CVP-R for the patients in the cohort. So, we have to be careful when we look at subgroup analysis because the study is not powered for these endpoints, nor is it powered appropriately for the subgroup analysis. But there is a suggestion that the impact of BR was most profound when compared to CVPR as opposed to R-CHOP. I think that's very relevant to Canadian practice because prior to switching over to BR, CVPR was the preferred frontline therapy in almost all Canadian centers. So, a head-to-head comparison with the previous frontline therapy, I think this trial really is reassuring that BR is a better treatment in the frontline setting. So time to next treatment is not usually an endpoint that's ever built into a trial as a primary endpoint. There can be differences in terms of physician preferences, in terms of when to start a next treatment. But for the most part, it's a very clinically relevant endpoint. So when patients finish one therapy, the more time they can get off treatment, I would say the better for that patient in terms of not needing to be exposed to extra toxicity, not needing to be exposed to the stress of requiring treatment. So in the StiL update, what we learned was that the time to next treatment was significantly longer for patients who had received bendamustine or rituximab, suggesting that these patients really were able to stay off treatment longer. And that is one of the primary goals right now in terms of managing patients with indolent non-Hodgkin lymphomas. So within the BRIGHT trial, the time to next treatment endpoint was not reported, but the fact that fewer patients went on to receive a second-line therapy in the BR arm, again, would fall in line with the improved time to next treatment that we saw reported in StiL1. So it's always difficult to interpret overall survival data in patients with indolent lymphomas. So they can go on and receive, a multitude of next line of therapies, and particularly in a trial like this where there is crossover amongst the different agents, the overall survival can be impacted on what the patient crosses over to. So the fact that more patients crossed over to the bendamustine rituximab may have impacted and diminished a chance of seeing an overall survival advantage. But I think it's hard to say overall. These patients do live for a prolonged period of time, and still within the context of this follow-up, it may be hard to measure overall survival impact. So I think looking at the results from both trials, I think the long-term safety data is reassuring. So the BRIGHT trial has suggested that there may be a slightly higher rate of secondary malignancies with bendamustine and rituximab, although if you look more closely at the data, it does seem to be most associated with a higher risk of non-melanoma type skin tumors, which are generally managed by excision and not threatening to the patient. So I think that's something that maybe needs to be looked at a little bit more closely. Patients may need to be surveyed for relatively benign skin tumors, but I think it was reassuring that there was no signal from either trial that there was a real concern for other types of secondary malignancies being increased with BR. Similarly, in terms of overall death rates between the arms of the trial, there was no suggestion that that was any higher with bendamustine or rituximab compared with CVPR or R-CHOP.